welcome all of you to the University of Wisconsin Global Health Institute's 2021 Symposium from Dejope and Madison. I also proudly want to acknowledge the Ho-Chunk Nation on whose lands I'm grateful to work and live as a guest. I give many thanks to all of you for being here and joining us. We realize what a challenging year this has been for everyone, for all of you, whether you're working on the front lines, like our upcoming panel, working in the community, working at home, or just working to survive. As Jonathan said, my name is Yannis Dupessis. I'm one of the associate directors of GHI. I'm incredibly happy to be facilitating this afternoon's discussion on some of our local communities' approaches and lessons learned from the past year's COVID-19 pandemic. As our leadership team thought through the theme for this year's symposium, we kept on coming back to the concept of resilience in all its forms. Resilience as individuals, resilience as communities, and resilience of the entire health system. We're incredibly happy to bring together this panel of distinguished providers representing all of the aforementioned pillars, representing those individuals, communities, and how the pandemic has affected our health systems. We thank you all for being here. Our vision at the Global Health Institute is to advocate equitable and sustainable health across Wisconsin and the world. We welcome all of you from near and far and really look forward to your participation and your contributions. It really is my pleasure to introduce our distinguished panelists. We'll spend the next 40 or so minutes hearing each of the individuals' thoughts and experiences. At the end of the session, we'll have time for discussion, so please use the chat box to direct questions to the panelists, and I will do my best to consolidate them and facilitate the discussion. I will introduce each panelist individually, at which time they will discuss their thoughts. First, it's my real pleasure to introduce our first panelist, Brett Bentley-Thompson. Dr. Bentley-Thompson is an enrolled member of the White Earth Band of Ojibwe in Western Minnesota. He is a clinical assistant professor at the University of Wisconsin as a palliative care physician. Currently, he's the faculty director and principal investigator for the 5-year, $1 million Indians into Medicine grant, re-awarded to the Native American Center for Health Populations and Professions at UW. He serves on the Council of Elders for the American Indian Science and Engineering Society and has served 6 years on the American Indian Cancer Foundation Board of Directors. He is also the former national clinical lead for palliative care for the Indian Health Service. Welcome, Dr. Thompson, and thank you for joining us.
Miigwech Yannis. Uju Anin Niji Bamadzig. Bejuko Kamiganan Digo, Minawan Nekta Wachi Web Digo, Indu Dame Mikanak, Kawababa Ganaka Gandun Jaba, Madison, Wisconsin, and Da'ao. My English name is Brett Bentley-Thompson. As Yannis explained, I'm a palliative care physician at UW. I'll translate my introduction. So I said, hello, my fellow human beings. My name's Bejugo Kamiganang, which is the first Ojibwe name I was given, which means first layer of earth. And I'm a member of the White Earth Band of Ojibwe, Gawa Baba Ganakug. We call it the medicine box of the Ojibwe. And my clan is Turtle, and I live in Madison, Wisconsin right now with my beautiful wife, Antonelle, who is Navajo, born and raised on the Navajo Reservation in Shiprock, New Mexico, and my 2 beautiful daughters. So it's my pleasure and my honor to be able to talk to you today. I hope I am going to answer some of your questions and give you some food for thought and identify some of the issues that we've faced as Native people. But I will give the caveat that I'm only one Native person, mixed blood Native person, and I'm one member of a huge tribe, and of which there are hundreds of tribes in the North American continent. So there's no way I can speak for all Indians, which we're frequently asked to do as people of color, to speak for everybody. And that can be quite a burden. So I give that disclaimer. So miigwech is I can see my slides. Can you all, Yannis, can you give me a?
If you could share your screen, that would be great.
Oh, that would probably be helpful. I'm glad I asked.
If we need to, we can help out doing that. So
I've got it. I just had a 60-something moment. Okay, looks like we're getting closer here.
Yep, sounds good. If you could just, yep, there you
All right. So, as I was thinking about doing this, giving this discussion, and I hope it's a discussion and not a lecture, that this is the latest pandemic in Indian country. As a lot of the other folks in the people of color they represent, this is not our first pandemic. Actually, nobody's history, this is not our first pandemic. But it's been, we've endured a lot of pandemics. And so I'm going to give you a little bit of a history lesson on who we are. The way I look at our history, our tribe's history and tribal history in the North American continent, what we call Turtle Island, can be a very different view from what maybe you're taught in grammar school or subsequently even in college. But so, the history between tribes and the US government, tribes are actually sovereign nations within the borders of the United States. They're, and these are, the status is through treaties. So in some ways we live at the pleasure of Congress. That sounds way too nice a phrase to, for what that means, but there are currently 574 federally recognized tribes within the United States. That does not include Canada. That's the lower 48 and Alaska. And there are hundreds of other tribes that are not federally recognized. Either they were never recognized or they were terminated by Congress during a period like in the 1950s and 1960s, including those of you that are in Wisconsin, the Menominee tribe, who fortunately were able to get their federally recognized status back. So during that time period of 50s to 60s, the loss of tribal sovereignty affected over 12,000 Native people in this country. And we lost 2.5 million acres of trust land that was actually promised to these tribes through treaties in the previous hundreds of years. So there are 100 state recognized tribes and over 100 tribes currently seeking recognition or reinstating recognition. And I actually have given lectures solely on that, but it gives I think the biggest point is that tribes are sovereign nations, and this has actually helped us in a lot of ways as we've dealt with the current pandemic, with the COVID-19 pandemic. So I'll also point out that there were 378 treaties. Depends upon which source you look into, but the National Archives, 378 treaties were signed with tribes through 1871, but sadly, none were fully honored. And that'll be part of this discussion in the next few minutes as well. So as the title suggests, there's a long history of pandemics in what we call Indian country. And Indian country to me is defined as what I said, Turtle Island, this North American continent, and the tribes that are historically have lived here since time immemorial. So prior to contact, there's a lot of discussion amongst scholars. As Indian people, we don't think about it a whole lot, but if we look it up and study it, the numbers of how many people, how many Indigenous or Native Americans were on the North American continent at the time varies widely. But one thing they do agree pretty well on is whatever that number is, however many millions of people those were, whether it was 60 million, which is kind of the most accepted number, that within the first 1 to 2 centuries, 80 to 90% of those populations were killed or died as a result of violence or disease in the first century or two post-contact after Europeans arrived. Smallpox was one of the biggest pandemics that we faced. Chickenpox, influenza, measles, whooping cough, all these diseases that we luckily don't have to think too much about today. That they were devastating to our communities. I mean, whole whole groups or tribes of people were decimated or extincted by these diseases. And then 1918 Spanish flu, affected both Alaska Natives and the tribes in the lower 48. About 80% of the deaths, some scholars have written, occurred within the Alaska Native villages and tribes and peoples of that land. And then the more recently, the H1N1 pandemic, the mortality rate amongst Native Americans was 4 times higher than the general population. Luckily, we're not, we haven't been quite there with COVID because we've been able to intervene, but the numbers, we'll share a few numbers in the subsequent slides, that it's still quite high. So here's a slide. We're instructed not to share too many statistics, but I think these statistics are helpful and bear on the story that we're trying to tell today. And as you can see, Native Americans are not alone in these numbers. If you look at the bottom row, the death rate compared to white non-Hispanic peoples for Native Americans was 2.4 times higher than whites. Hispanic or Latinx people 2.3 times. So we're Black. The Black communities, we're all right around 2 times greater, and there are some clear reasons for that, and others that we're going to continue to figure out on why we're affected so greatly. So the personal cost of this, both as as individuals and as tribes and as community members, one of our biggest one was the loss of our elders, which every population and every community suffered and continues to suffer. But our elders are keepers of our language, and language is the great bearer of culture. One of my elders once told me, and that's really true. I mean, try telling a joke in another language. It just, if you don't know the language, it just doesn't work. And as far as our ceremonies and our our spirituality, the way we communicate with each other, it's when we lose our elders, every elder that we lose takes that part of our culture with them. And that's a very natural thing. But when there is a high loss of our elders, our communities suffer greatly. So the comparative burden in some ways has been, enormous and disparate. Just if we think about that, the loss of our elders. So these contributing factors that we think about, which are across, I think all people of color within the United States and across the world as we deal with COVID-19. We live in multi-generational households, so the young are interacting on a daily, hourly basis with the elders. So passing the virus is easier. The virus is easier to infect that way. Poverty, I hope that goes without saying, that poverty alone is a risk factor for healthcare and for dealing with either chronic or acute illnesses. And then chronic diseases that we live with, diabetes and obesity, those are what we believe are independent risk factors for survival and mortality with COVID-19. And we do unfortunately have a lot of diabetes and a lot of obesity, in part because of poverty and other reasons. It's hard to eat a really healthy vegetable, good fiber-laden diet when you're just trying to feed your family on a very low income. And then one thing that goes back to the treaties, and that they were never fully, none of them were ever fully honored, is that the historical underfunding of the Indian Health Service which includes our Indian health centers and the monies that are distributed by Congress to tribes who have decided to be what we call self-determined or run their own health systems. The money that would normally be used by the Indian Health Service is given to the tribes, and they administer their health care in the way that they see fit. But that's still a woefully small amount of money compared to the per capita for the general population. And these are some of the numbers that might be helpful. This is actually pulled from the General Accounting Office. These are the most recent per capita dollars that are spent on healthcare in the United States. So Medicare, you can see that 13,000. Medicaid beneficiaries, their per capita spending is around 8,000. The VA, 10,000. And another per cap that we often put in here, but it's not in this slide, is the federal prison systems. The per cap for those people per person is around $5,000. So the Indian Health Service, which the government is charged with by treaty, which is the highest law in the land, second only to the Constitution, with agreements between nations, between the United States and other nations. They're promises basically that were given to Indian people and tribes in trade for our land. We gave up our land base, and we were promised healthcare was one of those things that we were promised throughout the treaties. And we have to, this is not the budget from Congress to the Indian Health Service and those other health systems that I mentioned within Indian Health has to be negotiated every single year. It's not a given line item, unfortunately. So we operate at horribly low budgets. So, you know, this is what I was told or really wanted to talk about. So I pulled some pictures off the internet, and actually I know some of these people in these pictures. Lance Whitehair is in the bottom, who that's Dr. Lance Whitehair, one of the medical students I was privileged to mentor years ago, where he just gotten his vaccine down on Navajo. The banner in memory of relatives is up on one of the reservations in, I believe, Rosebud in South Dakota. Somebody's just made a memorial to the elders and the relatives lost, and you know, a very solemn picture of a funeral as they're going, you know, taking one of their community members to burial. The Navajo Nation, in the picture below, you know, they locked down their reservation, which was one of the ways that they were able to control the pandemic in their communities, and they were very strict about the curfew. And the people followed, luckily, listened to their leaders and followed. So that was one of the ways that they've continued to survive this. So the tribe's responses, as I've alluded to, you know, because we're sovereign nations and because we have the ability to control and work with our own communities and make the best decisions locally for our own communities, a lot of the tribes did really well in managing, and are continuing to do really well in managing both control of the spread of the virus and the vaccine, this distribution of the vaccine, getting those into the arms of their people. The vaccination programs, luckily, tribes were able to decide whether they got their supply from the state or from the Indian Health Service. And, you know, even though IHS is, you know, sorely underfunded, this was something that they did pretty well, actually, for tribes. And if tribes decided to get their vaccine supply from IHS was able to, through their supply chains, get it out to tribes fairly quickly. And once it was in our hands, in individual tribes' hands, then we were able to set up and distribute those as we saw fit. I'll give an example, a personal example of our family and how we got our vaccines. You know, I was lucky enough to get mine through work, but my wife, who has you know, autoimmune disease, which a lot of us suffer from, a lot of Native people suffer from, and so she's immunosuppressed by the medication she takes. You know, she was. I've been sleeping in the basement for the last year or so. I don't bring it home to my wife because she's at high risk for contracting the disease. So like a lot of Americans, you know, we've been living in fear of her contracting this disease. But we live, as Giannis said, you know, we live on Ho-Chunk land, and the Ho-Chunk Nation was able to get their supply into their own community members, and they did such a good job within several weeks that they were able to offer the vaccine to non-tribal members, so native people who live in their service area, but are not tribal members. So my wife and daughter, who was over 16, were able to get their vaccines through the Ho-Chunk Nation. So we thank them so much. Navajo, you know, got tens of thousands of doses into their community and into their people, and they too. So a lot of tribes have reached out to other tribes within the area, and I will tell you that if we had the supply of the vaccine, I know that we would be vaccinating the communities around us as well. And actually, a lot of the tribes have agreed to vaccinate non-tribal members, but are members of those households of their tribal members. So if they're married to a white person or a person that's not a tribal member, they have given those to those community members as well. So there have been both challenges, both rural and urban. I will say that you know, not every story is a good one. It's been really hard for some of us, especially our urban people, because the majority of us live in urban areas, to get vaccines into our arms. And we're still struggling with that. So there's some references. I know I'm maybe a little bit past my time, so I'll stop talking and thank you for the opportunity, and I'm looking forward to questions.
Thanks so much, Dr. Thompson. We really appreciate your participation and facilitating the discussion. As we outlined, please, all of the participants, feel free to put in questions in the chat box, and we will do our very, very best to get to them at the end of the session. Next, it's my pleasure to introduce Dr. Patricia Tellez-Giron. Dr. Giron is an associate professor in the UW Department of Family Medicine and Community Health and chair of the Latino Health Council of Dane County. Raised in Mexico City, she received her medical degree at the National University of Mexico and moved to the United States in 1993 to be with her family and to continue her education. She completed the UW Family Medicine residency program and joined the faculty thereafter. Her clinical practice is at Winger Clinic in Madison, where more than 90% of her patients speak only Spanish. Tellez-Giron has chaired the Latino Health Council in Madison for 20 years and has been the medical director and main presenter of a monthly health education Spanish radio program for 17 years. She has received many awards for her community advocacy, HIV work, and faculty excellence. Her honors include the UW Family Medicine Department Mark Hansen Lectureship Award, the UW-Madison Outstanding Women of Color Award, and the 2011 City County Reverend Dr. Martin Luther King Jr. Humanitarian Award. We are incredibly happy to have her join us today. And so Dr. Tellez-Giron, thank you for being with us today.
Thank you very much. And thank you, Brett. That was a wonderful presentation. And let me just share my screen here. And I think for all of the presenters today, can you see my slides now? Yes, perfect. It is a little bit difficult because we are talking about our populations in a very short time. So we're trying to do our best to fit every detail that we want to talk to you about, but this is my information. So if you have any questions or you want to contact me afterwards, I will be happy to talk to you. And very important of why we are talking today about this topic. The Latinx population is now the largest minority population in the United States. So I always love to include the actual number, 60.6 millions in the United States. And despite all the things that you see in the news and the issues that we have seen, particularly more over the past 5 years or so about our population that is still undocumented in the United States, the majority of the Latinx population are actually American citizens, unlike our brothers and sisters that you just heard before me. We were native of this continent, and many of us native of this country. So, that is very, very important to recognize, because I think, again, the highlight is put on our brothers and sisters that happen to be here undocumented for reasons that hopefully are obvious to people. Nobody comes to this country hoping their life to be worse or to make their life miserable, not understanding the language and working hard. They come here because of the necessity to provide for their families. So it's very, very important to keep that in mind. We are a very young population and we are aging as we go. And we have a lot of healthcare disparities, and I'm going to talk to you briefly about these disparities because we started this pandemic already in disadvantage. So as I was talking before, we have a lot of people still, about 12 million people that do not have documentation here in the United States and what it comes with it. Still, many of the Latinx speak a different language at home than English. And we have a very high poverty rate. You see it 29% versus 7% of the white population. We're more likely to be uninsured. So here in Wisconsin, if you see 23% compared to 6% of the general population. There are a lot of needs in our community, but particularly mental health access that is language and culturally appropriate. We don't have a lot of health education. A lot of the people that are coming to the United States and even the citizens, the level of education is lower, and for health education is even lower. For the amount of people that I mentioned before, we don't have enough bilingual and bicultural staff that could provide for our population. And we don't have enough services that are language and culturally sensitive. And we all know that for better outcomes, when you are getting your healthcare, it is best if you have someone that can understand your language, that understands your cultural background. Unfortunately, we do not have enough Latinx health professionals. The healthcare system is very complex, even for us in the medical field. It is always a challenge to try to understand and to help our patients at the clinic. And then obviously transportation, particularly in Wisconsin, that it is so cold. It's not like you can just go out and go to the store as we used to do back home. So if you put all that background into perspective and then COVID hits, and we knew that COVID was going to hit us hard. At some point during this pandemic, there were 30% of the positive cases of COVID were in the Latinx community. It was amazing for me to see how at my clinic week after week, I will get report over and over of several of my patients that were presenting with a positive case, and that we will have to evaluate to make sure that they were safe at home, that they knew that they needed to stay home and not go out to work, that we could provide financial assistance for them to be able to do this. So nobody really came to us and say, hey, what do you need? We know you are in disadvantage. We know that you are studying already with health disparities. What can we do? And this is kind of a typical response from the community at large many times for our population, like it is for other populations. we knew that we needed to provide for our own from the inside. So that's what we started doing right away. I remember having the first meeting with all of our partners. And we knew that we still had the same disparities. We knew that we were overrepresented on essential jobs and that our people were not going to be able to stay home and work from home. They needed to go out. They were working on the hospitality industry and the food and agricultural industries, the factories. We saw that outbreak up north with the chicken factory. We started again with a high level of poverty, and unfortunately, many of the people in our population were not able to take advantage of the usual social safety nets because they didn't have documentation to be able to claim the federal reimbursements and things like that, and employment. So they needed to provide for their families. And even though some of them knew that they were infected, they knew that they needed to go out and continue being able to work to be able to provide for their families. So that was a big challenge of how to assist people with financial issues. And as I put it before, there were not a lot of resources to really inform the community, having a testing site for surveillance and follow-up of this. But we knew that we had some assets in the community. We knew that our population is very resilient, and we knew that we were going to pull through this pandemic. We also knew that we were going to depend a lot in our family and social networks. Unfortunately, again, this was kind of taken away from us as well, because even for medical services, we usually travel in pairs. Even now, my mom still comes to the doctor sometimes with me. And now through the pandemic, we couldn't follow that. And it was very difficult when people will end up in the hospital and they could not have their family members supporting them. That was extremely hard. It's still very hard for OB, for example, for deliveries. It's a great event for Latinx families, and usually families gather together at the hospital, and now we couldn't be supporting our pregnant family members. But we were willing to adapt. So we said, you know, I lost my job because of the pandemic, but I'm gonna find another one, and we will go out and try to find any job opportunities that we could. And for this presentation, very important that at least here in Dane County, we already had a very good group of grassroots community organizations that we have been working for many, many years. So it was easy for us to organize, get together, and start working. So in this graphic, just quickly to tell you, this is our community organizations. These are our community organizations and how well we are organized from before. So we basically pulled together, and we have an organization that is called the Latino Consortium for Action that has representatives from each of the organizations that we have in the community. We called for a meeting right away. The leadership got together, and we realized that one of the first things we needed to do is to provide financially for our population. So one of the first activities that we did was to start a relief fund, because again, we knew that we couldn't even start educating people about this without giving them resources. So we were able to actually get over $1 million and started providing exactly for the families that would not get benefits from the federal government. So we started organizing among ourselves without even previous administration experience. And we started having volunteers that will start calling the families. When we opened this fund, the 2 days after, we had about 2,000 families that were applying for this funding. So $1 million sounds like a lot of money, but actually it's not a lot of money for when you have such a need. And then we knew that we needed to educate our community. So we started doing, already had the radio program ready to go. We started doing Facebook Live events. And then we started doing presentations in several community groups. I think after a year now between these, because we're using the same strategies now for the education for the vaccine, I think I have done over 60 presentations about COVID and now about the vaccine. I have one actually following this presentation with a school in Verona. We knew that the youth wasn't going to come through because the youth is invincible, so they didn't think that they needed to protect themselves. So we recruited youth, my pre-med students, and they started helping us doing a youth education campaign that was amazing. We produced actually a rap song that is pretty cool. And then we started placing a lot of information that was accurate in our Facebook page, Consejo Latino para la Salud. And now we have videos about mental health, about COVID, about other resources in the community that people can access. We had to do a lot of advocacy to have a testing site where it will actually be focused on Latinx with culturally appropriate materials and language appropriate. We negotiated a lot with public health for several months until we were able to actually establish it. And then we work with the Latino Chamber of Commerce doing a campaign for safe businesses, because what we started seeing is that exactly in the Latinx owned businesses is where our community was congregating and they were not wearing a mask. So we started giving out free masks, brochures, so that people will get educated about why it was important to keep their business safe and their clients safe. So going really fast because it's a lot of information. One of the things that was really hard was mental health. Our population was already starting with stress from immigration issues, racism, discrimination. So as soon as this happened, we knew that they were gonna need more resources. So we started doing some videos on specific issues, and then we moved into doing videos about what happens when you are waiting for your COVID test, what happens if you have a COVID test positive, what happens if one of your family members is in the hospital, things like that. But then we knew that also we needed to have an individual strategy. So we also started offering with volunteers in the community one-on-one emotional support. So people will refer themselves through the different organizations that I mentioned before. And then my mother, who worked for 20 years with the elderly, started from our home, calling all of the elderly at least once a week to make sure that their emotional and financial needs were met. And then, of course, parents were virtual with education. So we also had to provide support for parents that now this was new to them, that they had to stay home with the kids. And obviously that has been very stressful for the families and for the kids. So to finish, and I hope I'm on time, we know that there are a lot of things that need to happen after this pandemic, and we are hoping that this is bringing light to our population and the needs that we have. It is very often that we are asked for data, right? In this country, data, show me the data. Unfortunately for Latinx, that data is not very accurate because many of our families, because of fear to immigration, and even for the ones that are citizen, racism and other things, the data is not very accurate. We need to have definitely more Latino professionals in healthcare, and we are already working on it. We do a lot of mentoring with high school, pre-med, med, resident students to be able to increase the numbers. We need definitely more services because this pandemic obviously, show that we don't have enough as it is. And besides collaborating among us as community organizations, we really need to have more of the community at large organizations work with us. So that was a very quick trip through the things we have been doing. As I mentioned, now we are doing the vaccine, and locally with all the efforts that we have been doing, we haven't seen a lot of hesitancy for people getting the vaccine. We'll see what happens after what happened with JJ. That's gonna really, influence a lot of the things that we have been doing. but we are hoping that we get the trust from people so that we can continue.
Thank you so much, Dr. Telez-Giron. Thank you so much for your advocacy. Thank you so much for your work, and thank you so much for that wonderful overview. Finally, it's my pleasure to introduce Dr. Christopher Ford. Dr. Ford is a board-certified emergency medicine physician practicing in Milwaukee. He completed his medical school at the Medical College of Wisconsin and was recruited to the University of Wisconsin-Madison for residency in the Burby Walsh Department of Emergency Medicine by yours truly. And it's one of the best decisions I've ever made as the residency program director here. Dr. Ford further did a pediatric emergency medicine fellowship at Children's Hospitals of Minnesota and Minneapolis. He currently serves as the educational director for Infinity Healthcare in Milwaukee, Wisconsin, as well as serving on the Wisconsin Emergency Medicine Services for Children. Most recently, Governor Tony Evers appointed Dr. Ford as the chairman of the People Maps Commission, a group formed by an executive order from the governor to help design fair, nonpartisan maps for Wisconsin. We welcome Dr. Ford from Milwaukee and look forward to your contributions.
Thanks, Giannis, and thanks to the other two presenters, man. That's a some hard act to follow. So thank you to everyone for coming out here. My name is Chris Ford. I practice in Milwaukee, Wisconsin. I live here in town with my wife, Dr. Chowdhury. We both are University of Wisconsin graduates for residency. She's a pediatrician. So Giannis and everyone else, she says hello. And so, I like to get started here by giving you a little bit of background on where we practice and some of the hurdles that Milwaukee had to go through for the COVID pandemic, and kind of relate it back to some pillars in the community that have been there for a while and may be causative and likely explain why we have seen such the numbers that we have seen. So if you look here, this picture is of Columbia St. Mary's Hospital where I work. It is in the downtown area. We currently serve a very diverse population throughout the city of Milwaukee. We're one of the 3 downtown facilities. Here we see patients from newborns all the way up. I believe my oldest patient was 104 that I saw the other day. And I just completed a shift 6 to 2. So if I look a little bit glassy-eyed, that's why. So thanks for bearing with me here. So we can go ahead with the next slide. So here, it may be a bit difficult to see here, but this is data from the 2010 census. So being a part of the People's Maps Commission, I've become very interested in the census data. Hopefully we'll get our updated census data in August, but in looking here, you can see in 2010, and looking at all the demographics on the left side of the screen, you can see Milwaukee is now a majority minority population. We will assume that that will likely continue to be the case in our 2020 census that's upcoming. However, even though having majority minority populations, some of the spikes in COVID-19 that we were seeing were largely in the minority populations, in the Latinx population, as well as in the African-American population, as well as the American and Indian population. And so what we'll do is kind of delve a little bit more into that and talk about how those populations were affected specifically. Next slide, please. So, as was mentioned by Dr. Thompson, some of the ideas that we're hitting on here too are more so aiming at some of the social determinants of health. If we take a look here, this is a picture of Jeanette Kowalik, who was our outgoing health commissioner in the city of Milwaukee and a colleague of mine. And one thing that she harps on at all times is housing being health. So housing is health was a part of her initiative in going forward. She was paramount in making racism as being one of the crises of public health. Milwaukee was probably the first city to do so. And in that, other cities followed suit as well, Boston being one of the largest cities that followed suit, and taking a look at how these social determinants of health really affect populations and how it affects the general population itself are affected by COVID-19 epidemics and things before that that will contribute to staggering rates. In the city of Milwaukee, we see pretty staggering rates in terms of African-American home ownership. Now, if you look at it from a couple different perspectives, even from an economic perspective, if you think about how wealth is allocated throughout generations, if you have a population of African-Americans, especially with the most recent data that we have here, only about 28% of African-American families own their homes in the city of Milwaukee. Outside of that, aside from that allocation of wealth that's put towards the next generations, if you think about the housing that is available, in some cases, the housing that is available is actually making populations sick. My wife is a pediatrician in the inner cities of Milwaukee as well, and she's still seeing a large population of patients who are affected by lead, high lead levels in the house, and we're seeing high rates of infant mortality, low infant birth weights, things of those natures. And so if you take all that into account with how this has become such a disparity within the city of Milwaukee, you can kind of glean from that how a pandemic such as COVID-19 not only affected these populations and didn't create these disparities, but actually shone a light on it and demonstrated how these social determinants were being affected. We can go to the next slide. So here is taking a look at the segregation in the city of Milwaukee. And if you can look at this chart, these are the majority of major cities throughout the United States. And what you can see here is Milwaukee is rated the worst amongst all large metropolitan areas. It's even worse than my hometown of Chicago, surprisingly. This is taken from a study from the University of Wisconsin in Milwaukee here. What they did was they analyzed this data on a couple different bullet points. So they took a look at a lot of the social determinants. They took a look at the racial salary gaps that are had as well, the availability of jobs as well, and in that they correlated it to some healthcare outcomes too. So higher rates of obesity, higher rates of heart attacks, as well as low infant birth weight and mortality. And so all of this is just to say that all these things are playing a role in what we saw during the COVID, or we're still seeing during the COVID-19 pandemic. You can go to the next slide, which may illustrate it a bit better. So in looking here, this is taken pretty early from some of the data that we had on COVID-19, right when my hospital was starting to see a large spike in COVID-19 cases. And so in looking at this map, it's more so of a heat map, which illustrates near the north side of Milwaukee, you saw a very high population, a high density of patients that were experiencing positivity, as well as high mortality and morbidity associated with COVID-19. Now, if you extrapolate some of that data onto the populations in general, you're seeing a lot of the bubbles in the middle of those being the highest densities of African-American populations. One thing that is really characteristic of this, and one thing that outgoing Commissioner Kowalik really touched on in some of her debriefing after leaving, is that they actually utilized the data that was available for higher rates of obesity, higher rates of metabolic syndrome, and bad outcomes from that. And what they saw was it transposed almost perfectly with some of the COVID-19 data that we were seeing and some of those spikes that we're seeing as well. And so although it's something that we know is related to those social determinants, and it is something that these populations are still being affected by, it was actually helpful in some respects in order to allocate resources to hospitals such as myself that were seeing such large numbers, whereas the rest of the state wasn't seeing it just as of yet. We can go to the next slide. So here, also Dr. Thompson touched on this too. This is a chart from the CDC, and as Dr. Thompson said, what we were seeing was, in terms of comparison to the Caucasian populations, we're seeing the Latinx community being affected in terms of COVID-19 positivity by about 1.6 times. We're seeing the African-American population being about 1.2, as well as the Native American population being around there as well, about 1.8. And so what this chart showed was, in looking at the population on the right side of your screen per 100,000 members of that community, you were seeing pretty significant rates of deaths in that community. So whereas if you look at it not knowing that data, where you're seeing around 80% of the population was Caucasian, and of that population, about 120 per 100,000 were dying. If you extrapolate that population by the smaller amounts of African-American populations throughout the state, as well as Latinx and American Indian populations, those numbers are relatively staggering, and something that we're continuing to fight against to this day, as we're starting to see another increase in the COVID-19 populations in Milwaukee as well as throughout the state. You can go to the next slide, please. So a perfect storm. This is an article that was put out pretty early on during the pandemic. David Bowen, who is a Milwaukee politician, really hit on some of the factors that were affecting people throughout the city of Milwaukee when we were seeing those exorbitant spikes. And one thing that he mentioned was not only the economic differences, not only the limited access to healthcare, which is tied into the social determinants and housing instability and ability to get to your physician's office. But there was also a large misinformation boom that was happening throughout. I can't tell you how many memes that I get from friends and family saying, is this true? Is this accurate? We can go to the next slide and I'll give you an example of that. So misinformation versus reality. So if we take a look here, we're seeing on the left side of the screen, and just as a disclaimer, I put up a fake box here just in case anybody screenshots it and says that this is what is in this presentation. But in looking at the left side of the screen is an example of one of those misinformation tweets that get out there. And so this particular tweet, Chinese doctors say that African blood is immune essentially to the COVID-19 virus, which we know pretty early on in the pandemic was not true. But this is just one of many memes and social media posts that went out. And you have someone with a PhD behind their name and it looks pretty official. And so people think in some form that they're immune, and especially if this is their main source of getting this information. But then you contrast that with the reality here. So if you look on the right side of the screen, these are the staggering numbers that we were having very early on, some of the staggering numbers that we continue to see. But in the very beginning, about 87% of our patients that we're seeing that had died of COVID-19 were African American. And some of these patients, I saw personally, I was one of the last physicians, one of the last people that a patient saw that I treated that ended up passing, unfortunately, from COVID-19. And so, these are the facts, and it continues to be an issue that we are trying to work against. We can go ahead to the next slide. So, this is something that I usually will talk to my residents about that I have currently at my hospital. I do lectures to some of our PAs as well, and kind of try to put them in the shoes of some of the patients that we have here. And so, when you talk about mistrust in healthcare, why is that there? In the African American population, I can speak from a personal standpoint, friends and families who have that mistrust towards healthcare, and also to my patients as well. When this picture here, we can actually see an actual photo in the 1930s of the Tuskegee experiment, in which a cohort of about 600 sharecroppers were inoculated with syphilis. And this was under the guise that they were receiving free health care. They were allowed to continue without treatment. At that point in time, there was no treatment, but continue to and progress to tertiary syphilis, where they began to have neurocognitive disabilities as well as manifestations of this disease. And so, this is one of many studies, unfortunately, of this type, in which kind of seeded that mistrust in healthcare. And so when we take into consideration why patients aren't taking certain medications, why they are not gung-ho about getting the COVID-19 vaccine, these are things that we have to recognized as a potential barrier, and this is something that we need to continue to bridge the gap on. I can tell you, just by myself being in healthcare, I've had friends and family who have gotten the vaccine because they know me. They know that I would not, perpetrate a lie, and I would want them to be healthy. And so, this is something that we always have to keep in perspective when dealing with our minority populations and dealing with our communities of interest as well. And go to the next slide. So as far as next steps here, so there are many things that we can do in order to help bridge this gap in our social determinants of health. One thing that we can always do is participate in special interest groups throughout the state. There are many initiatives, including led initiatives in the city of Milwaukee, groups that are aimed at reducing the amount of unsafe water and unsafe environments for kids. Voting not only in general elections, but also in those local elections, and becoming civically engaged as well, making sure that you know that these things are on the forefront of your representatives' minds. And as physicians and PhDs and people with a lot of fancy degrees, we can talk until we're blue in the face about what we feel is best for our patient demographics. However, these things have to come from within the community. So we can only be advocates, but empowering communities, empowering minorities communities, African-American, Latinx, whatever, to take these next steps and to continue to tell us what they feel would be best for their communities and how we can get there. And in addition, as it had been mentioned before in the previous lecture, we need to increase our minority representation in healthcare, not only in NDs, PAs, nurses, pharmacists, in order to provide some of that same assurance that I provide for my family and I provide for my friends and for my patients. We need to continue to push that issue and continue to leave the doors of communications open and advocate for our patients. So with that being said, I thank you all, and it's an honor to be here.
Thanks, Dr. Ford. And really, thank you all for your thoughts. We appreciate all of your work, both personally and professionally. A quote that we used this morning from the late Malcolm X: "When I is replaced with we, even illness becomes wellness." We appreciate all of your work and the collective we, not the collective I. I can't thank each of you enough for advocacy campaigns for yourself and your community. It's really an inspiration to hear. And I know on behalf of GHI, we look forward to working with all of you in the future. We have time for questions. And so in our remaining time, I'll try to look to facilitate some questions from the audience. And so please, if there are any questions, feel free to put them in the chat box. I think one of the things that I wanted to kind of put forward is, we had in our breakout session talking about health systems before, we had discussed that the concept of outlining some disparities or outlining some challenges in a health system often leads to unintentional consequences, both bad and good. And so, understanding and even having this conversation that we have is hopefully moving some of these things forward. And so how do you see this sort of the COVID pandemic and some of the challenges that the communities that you represent face? How is that, what are some of the positives, or what are we going to take from this moving into, COVID 2.0 or influenza, 150.0, or some of sort of the next pandemic and healthcare challenges? I know that has been asked numerous times by people in the background. So I'm curious to hear your. Maybe Dr. Teles Giron, you could tackle that one, and then Dr. Thompson and Dr. Ford could.
Well, definitely the power of collaboration, right? That we are all in this together. I think that sometimes we feel that whatever is happening somewhere else in the world is not going to touch us. And this is showing that we needed to all work together. And locally, again, the fact that we already were collaborating with other community organizations made this so much easier. So we are happy that we were already kind of ready for this, because we know that there are many communities that were not ready at all, that had to put together resources to be able to really start providing for their own. So I think for us, we grew together, we group, and now we have been even more together than ever. And we are thinking on doing many other initiatives that could take on what we learned with COVID.
Great. Dr. Thompson, do you think that there are any things, some lessons learned from this pandemic that will be applicable to your community?
Yeah, absolutely. There, I wonder if other communities, who are, their own communities, whether it's cities or counties, rather than at the state level, the vaccines being distributed, decentralizing some of that distribution and at least allowing those communities to get those vaccines into the arms of their people, whether it's at a government level or a health system level. I wonder if we could do better, like tribes have done when they've had control of that, to be able to get it into their communities. And each one of us talked about housing. A personal story: my sister-in-law down on the Navajo reservation. Housing is huge as far as social determinant of health. When my sister-in-law, our baby sister, got COVID, as did our father-in-law, my father-in-law, they had no place to go. They actually put my father-in-law, who doesn't speak English, in a very rundown hotel in a border town, Farmington, New Mexico. Nobody could speak his language when he was there. He really didn't know what was being done for him. So he kind of felt like he was in prison. My sister-in-law, we moved her, or they moved her into, because they have young children that they foster. We put her in a shed behind the house that had no running water, no electricity, no toilet. So we had the luxury of having enough money and funds to be able to send an Amazon toilet to her. But most people don't have that. So those multi-generational households, they just live and spread the virus. So how can our communities do that? Choctaw used some of their grant funding to buy what they call care cottages, which were 400-foot square, those little cabins like you see, and allow people to live healthily in those and their systems. So I think we have a lot of our communities of color have some great ideas that could be used for the greater population.
Thank you. I know that there's some questions coming in for Dr. Ford. I know, some of the disparities that you talked about. How do some of the disparities that you discussed kind of correlate to your work that you're doing with the governors, the People's Maps Commission? Maybe you can just give a very, very, very quick, brief overview of that. And so how have some of the lessons learned that you've taken from COVID and sort of this new initiative, how are you sort of driving that forward?
Yeah. And so the work that we're doing with the People's Maps Commission is ultimately attempting to try to create maps that are objective and that are representative for communities of interest, as well as people throughout the state of Wisconsin. From our hearings that we've had thus far, and again, this will be an ongoing process until we get that census data in August, what we've heard is that a lot of people don't feel represented in their current maps the way that they're drawn. And so this has been something that has been discussed by many people in the state of Wisconsin and many people throughout the country. And so, this really will be this year's plan, is to get a map that we can show that looks like it's representative of the populations that it reflects throughout the city of Milwaukee, as well as throughout the state. And so when you have that representation, and when you feel as though you are represented as a person and that your vote counts, in a perfect world, we will push forward and we'll be able to make these changes that we need. In this pandemic, we've seen that, especially here in the city of Milwaukee, we saw how vulnerable our healthcare system was. We saw that underfunding our public health department for a number of years really came to the forefront. Now, out of this, we were able to make changes on the go as critical care docs, as internal medicine docs, as well as emergency providers, making changes in terms of how we treat patients, how we used our patient flow models in order to help prevent bad outcomes. And so we need to do the same type of triage for our healthcare system and for our public health in general. And it largely starts with having people represented and giving people those opportunities.
Wonderful. I can't thank all of you enough. I really, it is inspiring what you're doing, and a big virtual Zoom round of applause for our panelists. We really thank all of you for being here today. Before everybody logs off, I just wanted to do some one or two housekeeping things. There's some really important things. Please remember to join us later on tonight. We will be restarting at 6:45 for the awards session, and at 7 o'clock for our keynote speaker, Maria Elena Humachano, who's an assistant professor in the School of Human Ecology, outlining resistance and resilience, indigenous philosophies of collective being as a recipe to living well. And so we look forward to seeing you there, and thanks so much to our speakers, to all of the rest of you for being here today. So we will see you later on this afternoon.
Thank you.
Thanks, everyone.